Hello everyone, welcome to this session on infectious diseases. And the first clinical syndrome is meningitis. So what is meningitis? Meningitis is inflammation of the meninges. What are meninges? Meninges are basically different layers of the brain. So we have the dura mater. So you can see here. So we have the dura mater. Okay. Then we have the arachnoid matter, and then we have the pia mater. So this three-layer forms the meninges, and any inflammation of that can lead to meningitis. Now, meningitis could be either bacterial. Example of bacteria causing meningitis would be Neisseria meningitidis, Streptococcus pneumoniae, H. influenzae, Listeria monocytogenes. For viral causes could be herpes simplex, HIV, mumps, and West Nile virus. We also have fungal meningitis. Most notoriously, it is the cryptococci, which is causing meningitis in HIV positive individuals. Okay. So, how to identify the meningitis? They would present with clinical classical symptoms of fever, headache, neck pain, vomiting, and sometimes with rash. Okay. Those patients who have probably and viral meningitis may have associated myalgias, arthralgias. So the best test to diagnose meningitis would be what is called as lumbar puncture, where we can examine the CSF and identify what could be the probable reason. The examination of the CSF would be the first tool to diagnose meningitis. So what are the different features of bacterial, viral, and tubercular meningitis? Let us focus on to that. So in bacterial meningitis, you find that the CSF will be appearing slightly turbid. If you check the sugar in the CSF would be much low, more than half of that of the plasma. If you look at the protein content of that CSF will be high because of significant inflammation. And predominantly, you'll find polymorph or neutrophil as the cell within the CSF. Okay, so it's very clear to identify bacterial meningitis. What about viral meningitis? In viral meningitis, CSF may appear normal or slightly cloudy. The sugar in the CSF would be normal. Protein may be either normal or raised, but predominantly you're going to find lymphocytes in the CSF. What about tubercular? Okay, so remember tuberculosis is caused an organism known as Mycobacterium tuberculosis. It's a type of a bacteria, so it has some features similar to bacterial meningitis. So you may find certain either cloudy appearance of the CSF, sometimes what's called fibrin web. That is, if you're going to keep the CSF for a long time, you'll find formation of web within the CSF. The sugar will be low, the protein will be high, something similar to bacterial meningitis, but the cells which you find in tuberculosis will be predominantly lymphocytes. Okay, so it looks quite easy here to differentiate bacterial, viral, and tubercular meningitis. But in a patient who's already received antibiotics, you may have certain other features. Now, suppose you are suspecting tubercular meningitis, can we stain with the acid-fast stain for the CSF? Yes, we can do. It's also called the Nielsen technique or Gudden stain. It's only sensitive in up to 20% of the patient. If you're going to have meningitis in immunocompromised individual, that means patients with HIV or organ transplant, think about Streptococcus pneumoniae, Listeria, and Neisseria meningitidis. Viral meningitis is much more common in patients who are exposed to viral infection, especially school teachers who are exposed to multiple viral infection from their students. So the patient would be presenting with flu-like illness, arthralgia, myalgia, and neck pain and headache. And on CSF examination, you would definitely find that the patient would have lymphocytosis. And the commonest virus which is causing viral meningitis would be enterovirus. Now, if the viral illness has a prodrome where the patient would come with the swelling below the ear, that is of a parotitis, then it could be due to mumps infection. The most common and most significant for the exam would be meningococcal meningitis. It's a notifiable disease where the patient would present with fever, headache, vomiting, sometimes diarrhea, photophobia, but the commonest is the rash. You can see here in this image, there are a lot of, we have maculopapular rash in the bilateral lower limbs. The patient may be hemodynamically unstable. Diagnosis based on the appropriate history, a physical examination where you can find this rash, and CSF examination. Okay, remember CSF culture can also be done Okay, blood culture can also be done, or you can do a blood PCR for the Neisseria meningococci. Do remember that the lumbar puncture would be contraindicated in somebody who's got a bleeding disorder secondary to disseminated intravascular coagulation, which is very common in meningococcal sepsis. Okay, the patient may be DIC, so you may not be able to in a position to do a lumbar puncture. Other contraindication being raised intracranial pressure. So before doing the meningococcal meningitis workup, you need to check the full blood count, look for any clotting factors, look for coagulation profile to rule out disseminated intravascular coagulation, because that's a common finding in meningococcal meningitis. Nasopharyngeal swab for the bacteria would be less sensitive. How do you manage meningococcal meningitis? If you're suspecting in a clinically meningococcal meningitis because of the typical symptoms and the rash, you can give them benzyl penicillin before shifting to a tertiary care hospital. If the blood culture or the lumbar puncture culture is definitive of meningococcal meningitis, you can switch to cefotaxime in appropriate doses, or if they're allergic to penicillin, you can give them chloramphenicol. How do you manage the contact? Remember, it's an infectious disease. It spreads from one person to another person. So close contact should be strictly isolated and given the appropriate antibiotics. The prophylaxis should be offered to household and close contact who are exposed in the last 1 week, irrespective of their vaccination, because we have vaccines now for meningococcal infection. And even they are vaccinated, a recent exposure may place them at risk of developing meningococcal meningitis. So it's recommended to treat them. So what are the options to treat contact? We have ciprofloxacin, we have rifampicin, we have ceftriaxone, we have azithromycin. Okay, so there are plenty of antibiotics which may work for meningococcal meningitis, but the preferred one is ciprofloxacin. Vaccination can be offered if the serotypes are known, or to unvaccinated close contacts. There is no prophylaxis available for pneumococcal meningitis. What we discussed so far is for meningococcal meningitis only. Remember, for pneumococcal meningitis, we do not have any prophylaxis